Good morning, everybody, and welcome to today's webinar. We're really delighted to have you with us today. I'm just going to pop my slides up just so that I can, you're not just looking directly at me, you can look at some slides. Here we go. Brilliant. So welcome to the fifth in our MDT Spotlight series. Today we're going to be focusing on occupational therapy. I'm really delighted to be kind of back after the summer. Our previous events are all available on our website if you are at all interested in going back and looking at all of the other specialist subjects that we've been exploring a bit more of over this series. My name is Chelsea Letts. I work at Bliss. I'm the Healthcare Engagement Programme Lead. If you have been to any of our other events, you will have seen my face facilitating all of these different sessions. I'm really pleased to welcome a few experts. So you're not going to be just hearing from me today, some real experts in their field of occupational therapy. So I'm just going to ask them to introduce themselves now. So Amanda, can I ask you to go first?
Yeah. Morning, everybody. I'm Amanda Laws. I work clinically on a level 3 unit as neonatal OT in Swansea Bay, and I'm also the lead OT for the Thames Valley and Wessex neonatal network.
Lovely, thank you. And Kate?
Hi, good morning. I'm Kate Whiting. I work clinically as an occupational therapist at level 2 unit in Bath, and then I'm the lead OT for the Southwest ODN.
Thank you so much. And I'm also really pleased to welcome Sharon here today, who is an expert in her own right. And she is going to be sharing a bit more about her experience on the neonatal unit as well. Sharon, I don't know if you wanted to say a quick hello just while we're doing introductions.
Good morning, everyone.
Lovely, thank you so much. Brilliant. So what are we doing today? Why are we running today's session? So this is how it will run. We're going to keep as close to an hour as we can, short and sweet, hopefully, filled with lots of really useful information. We are recording today's session, so if for any reason you need to duck out, then don't worry, we'll send around the link so that you can watch back. We're going to have a bit of an introduction by Kate and Amanda into occupational therapy on a neonatal unit, what it's all about, which I think will be really helpful kind of context for the rest of the session. And then Sharon's really kindly here to share a bit more about her experience on the neonatal unit, particularly how working with the occupational therapy team made a massive difference to her and her family's experience of the neonatal stay. And then we're going to have a bit of a Q&A structure. I'm going to be kind of asking Kate and Amanda some questions. Some of those are going to be taken from the registration form. So thank you to those who sent in some questions. And then we should have some time, hopefully, if that's not filled up the whole hour, for a few questions from yourselves, the audience. So if you have any while we're going through today's session, please feel free to pop them in the Q&A function that you should hopefully be able to see on your screens now. If you have any queries or questions, technical stuff that you, or questions for Bliss that you wanted to kind of ask, please again feel free to pop those in the Q&A, or you can pop them in the chat. We'll be keeping an eye on that throughout today's session. So I think hopefully if you have again been to any of our sessions, you will have seen some of these slides already, but really what we want to try and do with this series is make sure that we as an organisation, as Bliss, are advocating and supporting the increasing of awareness and knowledge about different allied healthcare professional specialisms. And obviously today we're focusing on occupational therapy. We really want to support and empower you as healthcare professionals to think about how these roles integrate into the wider neonatal team, and establish how important these are as roles, particularly when you're thinking about the delivery of family integrated care on the neonatal unit, and how crucial they are for that. And we also have to acknowledge that we know that there's a bit of a challenge around inequities of service for all of these roles, but we're seeing that get better and better all the time, which is brilliant. But we know that that will have an impact on how parents can feel like partners in their baby's care because of how important these roles are to making that happen. So essentially, that's what we're trying to do today, and we really hope that you enjoyed today's session. I will stop sharing my screen now and pass over, I think, to Amanda and Kate, who's going to give us a little bit more background, so that we can then kind of explore that all a little bit more. Thank you.
Okie dokie. Thanks, Chelsea, and thank you so much to Bliss for giving us this opportunity to talk about our role. I think it's been great that so many units have more AHPs on the unit, and I think there is some misunderstanding at times about our different roles, so it's great to have the opportunity to explain what we do. So can you see all my slides?
Yes,
Brilliant.
we can.
Okay. So I'm going to start off by talking a little bit about how neonatal OT helps families on the neonatal unit. So I think the first thing to say is that whatever area an OT works in clinically, their main focus is occupation. So we consider, what does an individual need, have or want to do on a daily basis. We look at the person. Do they have the skills to do what they need or want to do? And we also look at the environment and whether that helps or hinders the person in doing the task. So when you're working on a neonatal unit, lots of people say to me, well, why does a preterm baby need OT? What does a preterm baby need to do? Well, the main goal for the baby is to adjust to life outside the womb. The neonatal unit is very different, just at a time where a baby's nervous system isn't fully developed and fully ready to deal with the outside world. They have to manage light, noise, handling, and some uncomfortable procedures. In other words, they have to learn to self-regulate. And that's a real challenge for them to maintain their autonomic stability in this very difficult environment. And we know the best people to help the baby regulate are the parents. But when faced with a neonatal admission, parents are often usually having real difficulty managing their own self-regulation. It's a hugely emotional time. Parents are often in shock. They're worried, scared about what's happening to their baby. So in the neonatal role, baby and parents are the focus for OT intervention. And because we're trained in mental health as well as the physical and medical side, OTs are able to support the optimal development of the baby alongside supporting parents in managing their own stress and anxiety, and to coach and support them to learn parenting skills or occupations. So we've mentioned about the baby's need to self-regulate and adjust to their environment. And the reason this is important is because preterm babies are born at a really crucial time of brain development. The newborn brain is experience development. So if the baby has positive experience, such as positive touch, the right connections in the brain fire, and that leads to the fire, they wire together, that leads to brain growth. If the right connections aren't fired, then those synaptic connections die. Even worse, if babies have unpleasant experiences, which a lot of the neonatal unit does, then it causes the wrong synaptic connections to fire. And that leads to the baby developing a stress-prone brain, which isn't great for later on in life. So knowing how important experience is to these babies, particularly in the area of brain development, is crucially important. The babies on a neonatal unit have the right experiences. So one of the main roles of the neonatal OT is to advise and coach families on developmental care strategies. So this is a range of strategies to reduce stress for the baby, and in doing so, you protect their brain development. As well as working with the families, OTs also have an education role, because we often do a lot of teaching on this to the wider neonatal team. These developmental care strategies include things like positive touch, how to handle your baby in a supportive way, skin to skin, protecting sleep, managing painful experiences, and feeding. Really crucial to help parents to handle a baby and carry out daily cares in a way that supports neuroprotection. So OTs are also trained in environmental assessment. So we look at how the environment impacts on the occupational performance, both of the baby and the parent. So we might start off by looking at the baby's immediate environment. What positions is the baby able to be most comfortable in? What type of positioning supports do they need? We explore the sensory environment. How is the baby responding to light, to sound, to handling, to manage those uncomfortable procedures? And at the same time, we're also supporting the parents with coping strategies, because we know the neonatal environment is really stressful for them and really difficult. And of course, the best environment for the baby is to be close to the parent. So we encourage parental presence and having their baby in skin to skin as much of the time as possible. So as we've already said, the neonatal unit is such a high stress environment. Parents need a lot of support to manage that. Neonatal OTs use their mental health skills to support parents with managing stress, finding relaxation strategies. So, for example, if a mum is worrying about how much milk she's expressing for her baby, and that's a lot of pressure for a lot of mums, we can support the mum with breathing techniques or visualization strategies that almost distract the mum so that they're not focusing on the milk, and then the milk production increases. OTs explore and support parenting occupations. So we can support parents with juggling, or the practicalities of juggling life at home and time on the neonatal unit, and also helping parents manage their own self-care. When parents have a baby on a neonatal unit, often they feel really guilty about doing something nice for them when their baby's in hospital. But just as if you're on a plane and all of a sudden there was a problem, you'd put your own oxygen mask on before looking after your child. So supporting the self-care of the parents is really important for them to stay strong to look after their baby. As well as the individual parent support, we help parents really sort of engage in care. OTs have a lead role in the implementation of family integrated care, and that's all about supporting parents to be partners, to be true partners in their baby's care, and to help them develop close and loving relationships. And this enables parents to become their baby's primary carer, which strengthens attachment and bonding, which is so important for optimal long-term outcomes. When babies are reaching the time where they're planning towards discharge, one of the most important occupations, one of the most important tasks the baby needs to do is to be able to feed independently. And OTs have a huge role in this, obviously collaborating with our speech and language therapy colleagues who lead on assessing safe swallow and suck feeding. But OTs support this by enabling the baby. We might look at positioning for feeding. We might be helping the baby with state regulation, so they're alert to feed, and to manage the environmental aspects of feeding, because we know if when babies are trying to coordinate their suck, swallow, breathe, if it's too light or it's noisy, that's really distracting and the baby shut down. So we have a big role in feeding. And then obviously thinking about, going home when the baby's ready to leave the neonatal unit, that's just the start of the baby's journey. OTs have a long-term lens and have skills in early intervention. So we provide anticipatory guidance to help parents really support their baby's development. We work on continuing to nurture the attachment and bonding. Many neonatal OTs work in follow-up, carrying out developmental assessments to ensure baby's development is where it should be. And if baby has unfortunately had any brain injury or has already got a known diagnosis, then obviously we can either provide specialised intervention to target that, or we refer to community services when needed. So if any of you have attended these webinars before, you've probably seen this slide already. So this just shows you how we organise our intervention. So at the bottom, we have our universal intervention, and this is where we embed principles for care for all babies on the neonatal unit. It encompasses family integrated care, developmental care, baby-friendly initiatives, and we normally organise this intervention through education and teaching, cot side or running parent and baby groups. Then we have our targeted intervention, and these are pathways of care for targeted groups, so screening of high-risk infants who are more at risk of neurodevelopmental outcomes. So these are our babies that are born before 30 weeks, if they've got birth weight below 1,500 grams, or if they've had an early brain injury due to a birth trauma. And that's how OTs prioritise their caseload on the neonatal unit. And then we have our specialist offer, and this is where for the more complex babies, we do individualised assessment and intervention care plans, developmental care plans, and really provide specific one-to-one intervention. So I'm going to hand over to Kate now.
Thanks very much. Thanks, Amanda. So yeah, alongside the clinical OT roles, we've also got these new neonatal OT ODN roles. I think if you've watched the other webinars, you know that this is the case for all the AHP groups, and really they came off the back of the neonatal critical care review, where it obviously highlighted that the inequity that Chelsea talked about at the beginning of the session. So these roles in themselves have various work streams. I'm not going to run through every single point in detail, but just to give you a bit of an idea of how the roles are really trying to support the growth of the OT workforce as it stands currently. So initially, there was quite a large piece of work that we needed to do with regards to benchmarking what the previous OT services looked like in neonatal units across England. But alongside looking at the acute provision, I think many of the ODN OT leads also were thinking about what follow-up provision there is that Amanda's kind of touched on, but also what interest and skill base do we have out there currently? So who has got an interest in neonatal OT or has already made those steps to try and engage with learning more about the role, so that perhaps when future funding is made available, those OTs are kind of in a place to be able to collaborate with and think about in terms of supporting them into those roles. I feel that before kind of moving on to business case development for perhaps OT specifically, there's quite a lot of work to do on promoting the role and providing further education to stakeholders and the wider MDT really about the benefits that OT can bring to neonatal care. And that's not because OTs are new to neonatal care, they're very much not. It's based really on the current kind of figures in terms of numbers of OTs working on the ground. And it felt really that if we were asking them to be invested in thinking about including OTs in business case development, really we needed to spend that time promoting and providing that education so that they felt better informed to really why we can add to that parent's journey and support the families through their time on the neonatal unit. Much like the other AHPs, there are huge gaps still in provision, and that's a picture across England. Currently, there's no region that has over 50% of the current BAPM recommendations for OT staffing. So we have definitely made huge changes in the last 18 months, but there's still a long way to go. So really, when we have had access to funding through business cases or through the Ockenden funding that's been available, we've really had to think strategically within our roles about the utilisation of that funding and how it can be best placed to provide as much provision and support to families as possible. With workforce development, again, like I've just said, there's been a great change in number of OTs recently. being in units, and that's been fantastic. But a lot of those OTs are new to practice in neonates, and so therefore we've really spent time focusing on how we can best support them and instill confidence in their roles, and how we can support them to be feeling embedded within the wider MDT team. So that's involved quite a bit of peer support and really trying to network and support our OTs to collaborate within their own regions and cross-regionally, to be able to build on their skill base, build on their confidence, etc., and be able to know they can check in whenever needed. Now, unfortunately, we aren't able to provide clinical supervision as part of these roles, based on the hours that we've been allocated, and that is one of the challenges nationally that we're finding. But saying that, we are working to look at models to best support the OTs with clinical supervision and how they can access that. We're fortunate enough to have fantastic OTs nationally that run various educational courses, so we're really trying to support access to those courses, and some ODNs have been lucky enough to be able to fund places on those. But also we will support OTs to gain access to the NHS Learning Hub so that they can complete the free neonatal OT modules that are available. So that's been really positive. And like I said, sharing that good practice, sharing those real wins that they're already having with their other OT colleagues. Much like the other AHPs in clinical governance, we're supporting data collection within the different units and supporting OTs with doing so and completing audits. We've got quite a significant role now in putting together various developmental care and wider guidelines, so that we're really focusing on standardising that provision of care across England as well, and the different ODNs, and really supporting the fantastic QI projects that are going on at the minute. A real ability to show the good practice that OT is able to bring to the unit, and kind of sharing that more widely with others so that we can all learn from what's going well. And then just finally, we have done hopefully quite a lot of work, much like we are today, on raising the profile and awareness of OT, so flying that flag for neonatal OT. So that's been by engaging with stakeholder events, doing brilliant webinars like this morning, and really advocating for our OTs to have that confidence to perhaps submit abstracts or speak at national events. And the ODN leads themselves have actually run 2 free events to really support that further knowledge of neonatal OT. So one has been called Getting into Neonatal OT, and then the second one is Setting up a New Neonatal OT Service. And those have been full-day events. They've been free and have been open to OTs to come along, ask those questions, again, collaborate and get that peer support. So yeah, in a bit of a nutshell, that's the overall kind of ODN OT role.
Brilliant. Thank you both so much. There's lots of information to take in there, but hugely helpful to just give that context and understanding of where OTs fit in that wider kind of neonatal context. So thank you so much for that. Before we go into a few questions, just to unpick some of those things that you've mentioned, I'd love to just invite Sharon to share a bit more about her experience with her daughter on the neonatal unit, and why specifically kind of occupational therapy as a specialism really meant a lot to her and her family. So Sharon, I'll give the floor to you. Thank you.
Thank you, Chelsea. Thank you for having me here today. I thought I'd just quickly tell you a little bit of the background of why we were in there, so you have an understanding of where we were at before we met Amanda on the unit. Many rounds of IVF, desperate to have a little one, and finally we were pregnant, and something changed within the movements. They basically rushed me in for an emergency C-section, and Grace arrived. Grace was born on the 9th of December. I didn't really realise what was going on to begin with, because it was all quite frightening, especially with emergency C-section. It wasn't the plan. As I say, I'm a peer supporter on the unit now, and you kind of have a plan of how you imagine things are going to be, and that plan completely went out the window, and I have to try and find and navigate down a different kind of avenue. So we were on the unit, and when I could finally, when I was allowed to go in there, I didn't really realise the magnitude of what was going on. I was told she just had a heart murmur to begin with, And then I went in the middle of the night. I woke up in the middle of the night and wondered what was going on, so I came round from everything. Yeah, I started to realise the severity of like the situation. So Grace was had problems with her blood sugar levels. She'd had seizures. She had a stroke in my tummy. She had 2 holes in her heart, jaundice. Basically, she had a lot going on, and it was big stuff. It wasn't like she had, she had an infection as well, but the stuff was really big and really, really hard to take in. Actually, I feel quite emotional. I don't know why. Yeah, just thinking about it, I kind of feel like I'm back in the room. Yeah, so it was huge stuff. All these bits were I wasn't told all this in one go. Obviously, this was gradually throughout our stay in intensive care there. So quite early on, I really struggled emotionally. I struggled trying to understand everything. And it is like kind of like a grieving process. This wasn't the plan. It's all frightening. She's tiny. She's in an incubator. No one was saying the word home, so I was just worried whether we'd even make it home. So I had a lot of stuff going on in my mind. I couldn't communicate to the outside world. I didn't want to speak to family or friends or anything because I was just too emotional and really, really desperate for this little girl that we tried so many rounds of IVF to have. I just wanted her to be well. Anyway, Amanda came into the unit, and I was literally in the middle of having a bit of a meltdown, actually. And she was now I know that she's got the mental health training. It explains so much, because I could see she was trying to gauge whether I was ready to talk or whether I needed to speak to somebody. And she just kind of, I sensed the warmth from her. And I was like, all of a sudden, for the first time, because I couldn't communicate to anybody else, I was like, I'm ready, even though it was a lot of tears. And I just explained to her how frightened I was. I was frightened of how little she is. I was frightened of the wires. I just was frightened to hold her, and I didn't know how to go about this. Even though, don't get me wrong, the nurses and doctors were amazing there. It's just I felt ready to communicate at that time, and the way about her kind of made me feel comfortable to ask some silly questions as well, because I sometimes didn't understand like all the terminology going on, and I didn't want to look stupid as well. So I'd say, I don't really understand this. Can you break it down for me? Yeah. So Amanda gave me some tips on like the holding, the best way of handling Grace, because because of all the wires, I didn't want to, and I was frightened of seizures again. So I was like, I was really shaky, really nervous. Also, one of our family members used to come in and stroke Grace's arm, and the reaction didn't seem right. And I said to her, I just feel like she doesn't really like that. And Amanda straight away said, okay. And she explained about this, like the firmer touch. And from there on in, anybody that came to visit her, she just really calmed, rather than I could see she was agitated. Yeah, so it was just the things like that then we could pass on to everybody else. And I could say, Amanda, the OT said it, rather than me saying, please do this, which really helped. Yeah, so I had to first when we had the first MRI and the results saying that Grace had a grade 4 bleed, I did what most of the parents that I see now as a peer supporter do, and I went on Google, which was really frightening. And I kept hearing cerebral, and I don't know, it was too much to take in. So again, when I saw Amanda again, I was just like, what does this mean? Does this mean I was asking the questions that you can't even, looking back, it was crazy to ask them, but I was like, do you think she'll ever walk, or will she be able to talk, or and even then we weren't even talking about coming home. So it was, it was really tough. Yeah, so I had that moment of clarity where my mind switched, and I went, right, okay, so this is what's going on now. Now I need to know what I can do. While I was in my own self-pity for a bit now, and I've accepted. So I've gone through all those emotions, and now I'm ready to see what I can do to help her. What can we do as a family? So Amanda explained loads of different tips that would help us. And she also used to do like a baby and me group, which from there I learned about the Zaki hand. So on the unit, obviously we're not allowed to stay overnight. If I wish we could have done, but we weren't allowed to stay because it's not practical. And the Zaki hand is something that would give Grace comfort. And she really needed the comfort. And actually something Amanda mentioned earlier about the self-care, I stopped eating and I kept forgetting to eat because I'd get lost in the moment of being with Grace. And I remember Amanda saying, I don't really remember this, that have you actually eaten today? And I was like, oh, yeah, the self-care, I was forgetting about stuff like that because I didn't actually want to leave the unit, if I'm honest. And then she explained about the parents' room, which is really close by, so I didn't have to go all the way to the cafe because that felt like hours away. It's not, but it felt like it was too far away to kind of go for something to eat. So yeah, when you were speaking earlier, I was like, oh, I just remember something else that you did back then. Yeah, so there in the baby and me as well, Amanda was explaining, I don't know all the technical terms, but how the baby's hearing is really sensitive and how the light can be a lot. So I was then got a blanket to cover Grace, and the noise, I noticed Grace was really sensitive to sound and light, and she still is quite sensitive to sound like now actually, but yeah, so the sound, Amanda basically empowered me to be able to advocate for Grace. In that one of the nurses, they're so busy, it wasn't obviously done intentionally, but she banged the incubator door shut, and Grace flared her arms out and shook, and I was so frightened that she was going to have another seizure. And I actually, I've mentioned this before, I don't complain about when I go out for food. If the meal's awful, I don't complain about anything, but I had this thing in me where I'd already had the knowledge from Amanda that this wasn't right, and I actually spoke up, which my whole family is still surprised that I had the confidence to do. And I went and I said that's not, that, she's had seizures. I feel really uncomfortable with that. I understand that you're busy and everything and you're all amazing. And it's not that, it's just, I really feel we need to be really gentle around her because she does struggle with all these senses. And they were brilliant and everybody, so if it weren't for Amanda saying all about, how sensitive they are, I don't know how I would have reacted in that situation. But yeah, so I'm really grateful for that. Also, Grace was she was quite jittery as a baby, which I know now is quite common after brain damage. She showed us a way to wrap her up at the top half, which made her feel secure. And then all of a sudden we noticed everything easing, which was amazing. And also the main things that Amanda said, skin to skin is just, and it is, I've got goosebumps now thinking it's skin to skin. Whenever I held her, I would all of a sudden, I would just breathe. I was calm, and all of a sudden her sats were really good as well. So skin to skin, you just need each other. You shouldn't be in there really, she's still in your tummy should be really, so to have that skin to skin and going around as a peer supporter, seeing it as another way. I watch the parents now when they're having skin and it's skin to skin, it's the most beautiful thing. And the calm and serenity around that is immense. It's beautiful to see. It actually really relaxes me watching them having skin to skin. So yeah, she was saying, not to be frightened of the wires and different ways around that, but how important it is. And I realize now, just seeing how we were, emotionally and physically, the two of us needed that. And also not to be afraid to read and sing to her, do the things you'd be doing at home. She gave me the confidence to, and I did sing to her in there. My singing's not the best, but I did sing to her because I wanted to. I knew I'd be doing that at home. I was making up songs. I was singing things from Les Mis really badly. But yeah, it was great. And the reaction, I could feel like a nuzzling into me. It was beautiful. And we always did bedtime stories. And now knowing that all this, which is such a beautiful thing that you would do anyway, actually helps the brain development. So I was helping her but even though it's enjoyable, I was helping her brain to create new neural pathways, which is amazing. It's so simple, and that's something that I've learned from Amanda, and I advocate for it on the unit, is that it's those simple things you're helping, because you're helping your baby, and it's beautiful, and it's a lovely moment that you get to share with them, you know. So that was there was also other things like learning cues that I didn't really understand. I've never had a baby before, obviously, with rooting and things like that, I didn't know what all this was. So Amanda explained some of that. And also the one day when we had a breakdown of, she's got a grade 4 bleed, hydrocephalus, all these big words, she sat down and I said, right, this is big words. It's frightening me. Can you just explain it in a way that I may understand? And so she did, and she did it in such a gentle way, in a way that I needed to hear it right then. Because there's different stages, I feel, of this whole process. You need to hear things in a different way, and I think Manda's really, as an OT, can gauge exactly when you're ready to hear stuff, because later on in life, Grace does have full body cerebral palsy. She does have all these things, but I was ready to hear that later on. She did, she said it in a way that I needed to understand, and she knew I was ready for. And then luckily Amanda has all the links with the early intervention around here, so and there was an early intervention course, and Amanda knew that we would be desperate to kind of go for that. So anything like that, I was saying to Amanda, because obviously the fear is leaving as well. Leaving the unit is a big deal. Some people can't wait to get out there, and I understand. But I was the one person that was just crying because I didn't want to leave, because I felt so safe, and I was frightened of anything happening when I left, but I had hope for when I left as well. So not only was I getting little nuggets of things that I needed to keep me going in there, I also had hope for when I left, of different things that could happen when I left, and I know that's not the case for everywhere, and I find that really, really sad. That makes me feel really sad, because I feel every child that may have stuff going on really, really does need that kind of nurturing and support when you leave, because that's the daunting bit. You've got all this medical team around you in there, and they're phenomenal, but it's just you at home afterwards. So that not only did we have all the luxury of Amanda all the way through in there, we were so fortunate to have her out in the community as well. I know this is all about the neonatal unit, but that gave us something to look forward to, the early intervention course. And also knowing that Amanda was coming, continuity with Amanda, who's seen us from day one, hysterical, going through that grieving process, to accepting as best we can, and then to being ready to hear and want to and move forward and what we can do. And then I was like a sponge, and I just like everything that, just give me all the information, the positioning in the incubator with like a rolled up towel, I think we used, or something to make her cozy. That stopped her jittering. I was just like, tell me everything, just I'm ready. But you have to get to that point, and everybody's different. And I feel as seeing the OT role, they're very good at understanding when to say something and how to say it. And we're all individuals, we're all unique, and we're all processing differently. And I feel that's the difference. And that's what makes them stand out. And that's what Amanda stood out for us, and she became, she became someone that I spoke to, about all the stuff I was worried about. We had lockdown, and she used to pop round to see Grace, and that would be my emotional kind of, she's more like a counsellor, bless her. But yeah, so as you can see, the whole role of an OT as a parent is vital, because everybody else has got their other roles, and there's something missing there, and that's what you really need as a mum, especially with a little one that's going through so much, and it's really, really tough when you're in there. So I'm grateful that we have that on the Singleton neonatal unit, and I'm grateful that we've got physio and speech and language on there. Everybody has their role, and coming together as a team, it really, really works. I just hope everybody else gets that. Yes, so thank you anyway for having me. I hope I haven't talked too long, but thank you for having me. I hope that was okay. If there's anything I haven't mentioned, please say.
And that was more than okay. Thank you so much, Sharon. And I think you picked out on so many bits there, which I think is hugely helpful for everybody who's here today and watching back. So thank you so much for sharing your experience and how kind of this role particularly was really able to kind of support you with advocating for Grace and yourself, and really encouraging you to take that parent role while you're on the unit. So that, yeah, you explained that beautifully. So thank you so much.
Thank you.
Brilliant. So we have about 20 minutes and we're going to just try and get through a few questions that I think just unpick some of that with Amanda and Kate. Feel like we've covered quite a lot already in today's session, a bit about kind of what is a very alien environment, the things that OTs can really support with to kind of build that partnership with parents. I just wondered, Kate and Amanda, whether there was anything else you wanted to add about those specific things kind of from the kind of first couple of questions we were going to run through. Otherwise, I might just kind of start talking a little bit more about kind of the specific thinking about kind of that early intervention that you mentioned, Amanda, in your first slide. But just before we do that, I wondered whether there was anything more that you wanted to just quickly add about how to support that kind of occupational and building partnerships with parents.
I think Sharon, you voiced it beautifully, like literally gave such a personalised experience of that, which is so relatable, I imagine, to lots of the OTs working in the neonatal unit. And I think it's about being lucky enough as OTs to have that ring-fenced time to really get to know the parents as individuals, especially where they're at, which sounds like you and Amanda were able to do together perfectly, which is great. I think also taking that time initially when we're looking at building these partnerships to really hear the parents' voice about their infant, and really taking that time as OTs and being able to really listen to what the parents feel supports their babies when they know their babies, exactly like you've said, Sharon, aren't feeling quite so comfortable, and what their babies are like as individuals, because that's how we can best partner with parents to provide that individualized support.
Yeah, it's all right, and I think the beauty of the OT role is the fact that we have that that we are dual trained, and that our mental health skills, because babies don't come alone, they come in the context of the family. And I think, you know, as Sharon has said earlier, it's such a difficult time for parents. You never imagine when you're expecting a baby that you're going to deal with breathing support and incubators and that crazy, highly medical environment. I mean, it's difficult enough for any parent to become a new parent, but in that setting, it's really hard. And then when you have to learn those really complex new skills in order to care for your baby and care for your baby in the right way at a time where parents are terrified. I was talking to Dad last week, and he said when his baby was admitted, he literally lost his words. He couldn't speak. He literally couldn't speak, let alone take on complex information. So I think the OT role is amazing at helping parents connect with their baby and feel like parents, because often the impact of that is that parents feel out of control and not even like a parent. So yeah, thanks, Sharon. You did really great.
Yeah, and I think it's that individualized care, isn't it, that's so important to developing partnership with parents. I think if you can't kind of assess the family and the baby in that individualized way, which clearly is a really important part of lots of different roles, but particularly OTs, I think it's a really then difficult to build that partnership and really deliver kind of care in the way that you would kind of want to for each family. Thank you both for expanding a little bit more on that. So just to go back, so Amanda, you mentioned in your kind of the first slide, I think, that kind of OTs have quite a unique role in providing holistic support, focusing on early intervention, and you also mentioned having that longer term lens, which might be different to other roles on the neonatal unit. I wonder if you could just expand a little more on how important that perspective might be for babies and their families, but also for staff on the neonatal unit.
Yeah, it's hugely important, and I think for all AHPs we have the long-term lens, because we know from the research that babies born early, or if they've had a birth trauma, are at high risk of neurodevelopment problems later on, particularly in the areas of cognition, behaviour and emotion. I mean, half of all babies born at 28 weeks present with cognitive, emotion, behavioural issues at school age. and that's massive. So and I think it's very different approach to doctors and nurses, because their focus is keeping that baby alive, well, through the door. Their job is done, but we are thinking of the the whole long-term process. And there are so many factors that impact on that baby's ability to achieve optimal development. And one of the first things is secure attachment. We know that when parents are able to bond with their baby and have that secure attachment, that when they understand their baby's needs and they respond with sensitive, attuned parenting, that's going to promote a good developmental outcome for the baby. And that's what OTs are all about: enabling parents to be parents and promoting that attachment and bonding. We also work with the neonatal team and families to really read the baby, to understand the baby's individual responses to the environment, sensory experiences, and to minimise the impact of any unpleasant things, because a lot of those unpleasant things are life-saving. They have to be done, but we can balance that by making sure that they also have neuroprotective strategies. And I think, as in Grace's case, when babies have an early brain injury, OTs, along with other members of the team, provide the advice and intervention to minimise the functional impact of that injury, and to make sure that parents from day one are able to incorporate therapeutic interventions into their baby's routine, because we know that early intervention, particularly in the first 3 months, is key to that baby developing as well as they can. And if you could see Grace now, she is absolutely amazing. She is walking, talking, she dances, she plays, she's got the best sense of humour. She's, considering her tough early start, she has had an amazing outcome, and a lot, well, practically all that is down to Sharon, how amazing she was with her, and how she took on board all the advice of all the therapists.
That's so lovely to hear, isn't it? Sharon and I caught up yesterday, actually, so I was hearing a bit more about Grace and kind of going to school, and that's so exciting. So yeah, really, we're delighted that she's doing so well. Thank you, Manta. That's really helpful. I think the next bit kind of expands a bit on what you've just mentioned about those life-saving but quite unpleasant experiences that babies might have to go through on neonatal units. And one of the areas that might be a bit less understood about OT roles, I think, is around your role in pain management while they're on the neonatal unit. And I wonder if you'd be able to share a bit more about the OT role within that context, but also how you might partner with parents to support them to kind of help manage the baby's pain if they're going through kind of some painful procedures.
Yeah, thank you, Chelsea. I think discussing and talking about pain and discomfort can be quite challenging, can't it? But actually, I think if we are going to be partners in care with parents, and we're going to advocate and support parents in decision making in their baby's care, really we do need to be focusing on those conversations as OTs, and that's certainly something that we focus on within our OT roles. I think by really listening to the parents, firstly, to really hear about where they are at and where they feel able to provide that kind of support, comfort and presence for their babies, because exactly like Sharon said, you're going to be at very different headspaces day to day as you learn more and more and adapt to being on the neonatal unit. But also listening to the parents with regards to being the experts in their babies in terms of noticing when they're uncomfortable, noticing perhaps what does comfort them, and really listening to the voice of the baby when it comes to us being able to then move forward to support families with pain and stress. And I think by gathering that information and that insight from families, we're able to really advocate, hopefully, for them as well, to be present whenever it's possible, for any kind of medical procedures or interventions that might bring about feelings of stress or discomfort. I think obviously therefore thinking about the timings for the babies and for the families to be present whenever kind of medically able. So I think really that supports us in our roles to be advocates for families. And in terms of then having that information, we're better able to support all the amazing pharmacological strategies that we know can support babies through times of stress or discomfort. So we can really coach parents and perhaps work alongside them to be able to support things such as skin to skin or breastfeeding, if appropriate at that time, non-nutritive sucking with expressed breast milk, for example, perhaps using a soother, helping families to provide that comfort holder if they're not ready for that, being able to provide a finger to grasp and a soothing voice. So it's thinking also of how as OTs we grade those strategies, which again we do very much within our OT role, thinking about grading what we're supporting to be at the place where parents are in that time. So I think we use the role in many ways in trying to support stress and pain management, and really just doing it so that it's matching where the parents are with regards to their well-being, their anxiety, but also hopefully just trying to support that partnership in as a team and with parents, supporting reducing that stress and pain.
Thanks, Kate. That's hugely helpful. I actually also have some relatively newish Bliss information about this as well, which I'll pop a link to in the chat in a moment, which is aimed at parents, but to kind of support them with how they can support their baby when they are going through a procedure and what their role might be. So hopefully that will be kind of a bit supplementary and useful. So I'll pop that in the chat in a second. We've had one question come through the Q&A, which I was going to touch on now briefly before our last question. Both are a little bit more technical about the first about skin to skin. And so just from the Q&A, I think particularly there's reference to how this works in a level 3 centre. So Amanda, I know that kind of fits with you, but Kate, I'm sure there's relevance here too. About how responsive the medical and nursing team are to facilitating skin to skin on a daily basis with families, and the importance of it. Do you tend to do it regularly with those that you can see don't tolerate handling, which has kind of been put into, there is maybe kind of I assume kind of terminology that we use on the neonatal unit for babies that might struggle with that, because obviously we know that skin to skin will help in lots of different ways. So I wonder whether either of you would like to just comment on kind of how that works on your neonatal unit.
Yeah, I'm happy to answer that one. It's I think on my unit, that because my unit is very evidence-based, and the consultants medical team are really forward thinking. They know the benefits of skin to skin, and it is practiced very, very regularly. As Sharon said, she had Grace on her constantly. I think the interesting with the question around the extreme preterms is really interesting, and I'm actually carrying out a quality improvement project at the moment to look at this, because I think one of the barriers for skin to skin is when babies have umbilical lines. And obviously, when a baby's on their tummy, if they come out, then that can be really dangerous for the baby. So there's lots of anxieties around that. But there was a fabulous paper published earlier this year where they did, the team, it was an American team, developed a care bundle to improve in skin to skin. And I think there's lots of different ways in how OTs impact on this. So, for example, even in the first instance, if you've got a really tiny baby that's got wires, if you say to a parent, if a nurse says to a parent, do you want skin to skin with their baby? They're going to say no. They're going to look, they're terrified. They're really frightened to touch their baby. So they're going to say no thanks. And that I see that happening occasionally. Whereas I think from a therapeutic point of view, you would go in and you would say, did you know that if you have your baby out for skin to skin, it helps brain growth, helps your baby stabilize, you release oxytocin and manage your stress. You can talk about the benefits and then say, we can help you get your baby out by managing things in this way. So I think so skin to skin is happening. I think we've got a way to go in terms of managing skin to skin for extreme preterms and those on respiratory support. But there's a lot we can do, especially in the transfer. You know, Sharon talked about wrapping, Grace, earlier. I've worked with some really small babies that don't tolerate handling. But if you wrap them and keep them in flexion, and you get them out, and even better, if you teach the parents get their own baby out, baby is going to manage that transfer so much better.
And I think you mentioned there about those babies that are perhaps more sensitive to touch, but actually, again, it's thinking about that environment, isn't it, Amanda? And thinking, okay, if that is the case, what can we do to make parents feel most comfortable in terms of simple strategies, bringing those incubators down, bringing those chairs right in, opening those doors, and really supporting parents with a finger grasp, with comfort hold, with hearing that voice. So any of those positive touch experiences that may not be full skin to skin at that point, but still very much kind of advocating and supporting that kind of initial bonding and attachment experiences between parents and babies. And there's some amazing work going on that, again, may not be fully full skin to skin, but in terms of delivery room cuddles and really facilitating, even if babies are wrapped for thermoregulation, that they're still having that opportunity to be able to be on their parents' chest for a short period of time. And just when you're lucky enough to watch that experience, it's just magical. It just makes all the difference, even for a matter of minutes. So there's lots of positive things happening.
Yeah. And just one last thing, the language you use is key. So, for example, I've just been doing a survey, a parent survey and a staff survey on skin to skin, and it made me really sad that in one unit, and I did this across England as well, in one unit, a parent had said it was extremely important to hold their baby in the first 24 hours, but she'd been told by a nurse, it's best leave your baby alone for a little bit. And I just think, what message does that give the parent, you know, that the baby's better off by leaving her alone? And I think there are so many other ways, you know, we could have brought the baby out on a tray and done containment holding. But even saying to the parent, these are ways you can connect with your baby, rather than giving the impression that the baby's better off by not being touched by the parent. I think we really need to get away from that message.
Yeah, that's really important, isn't it? Thank you both. That's hugely helpful. We've had somebody ask whether it'd be okay to share the link for the research that you mentioned, Amanda. I don't know whether you'd be happy to send it directly to me, and then I will circulate it with the link to the recording and the feedback form. Is that okay? We'll do that.
Yeah, I can do that.
Thank you. So I think we've probably got time for one more question, and we actually had this through the registration form. Hopefully we've got time to kind of go through it, because it sounds more technical to me, not being a clinician. But whether you could share a bit more information on the developing vestibular system and when it's fully matured. I think there was an acknowledgement that on the unit, some staff obviously trying to protect the vestibular system, and that kind of being able to give a bit more information to the medical team would be really useful. So appreciate we don't have long, but Amanda, I don't know whether you'd be happy to expand on that a little bit more, shed some light on it.
Yeah, absolutely. Well, as you rightly say, Chelsea, supporting sensory development is a key role, and OTs have specific and specialist training in this area. And I think the first thing to say is that sensory development happens in utero in a sequential manner, and when preterm birth happens, disrupts that sequence. So, for example, vision should be the last thing to develop, but because babies are born early, that comes on board early. And it's not necessarily just vision that's impacted by that. It's all the other senses that should be developing, the vestibular system for one. So the vestibular system is your sense of moving through space, and it incorporates the sense of gravity and the balance in relation to the head. And I think if you think about the type of vestibular input a baby would have in utero, they get almost constant vestibular input because they're head down towards the end of the pregnancy. And yet when they're born onto a neonatal unit, they have the exact opposite. There's no gravity in the womb. When they're born early, they're flat on a bed. There's no vestibular input, and they've got a ton of gravity, especially if they've got equipment and splints and things weighing the baby down. So they're not getting the type of vestibular input. And I think that's probably what's probably more important. I mean, the vestibular system develops in utero. So some of the mechanisms, it's all around the inner ear, semicircular canals. They develop really early on. If you look at vestibular responses, so I think babies will get a weak MARA, where if you if you sort of like, if you're holding the baby and you drop the head, that's vestibular input. And that a weak reflex develops about 24 weeks, where by 30 weeks you've got a more full moro. So that gives you an idea about how it develops. But it's about giving the right vestibular input. And an example, rotation is part of vestibular movement. And when I first started in neonates, it was almost a badge of honour for neonatal staff. If you could flip, the Premi flip it was called, if you could move a baby from the front to back in one quick movement, you were considered to be an expert clinician. Where we know rotation is alerting for the baby. If you add speed into that, you're increasing the intensity. So as OTs, we teach nurses and doctors, rather than flipping the baby in one movement, we break that movement down. We would turn the baby a quarter of the way, put still hands on, talk to baby, then a little bit further, still hands. So you really break that movement down. So I think that's the main thing to think about, is balancing unpleasant sensory experiences with positive sensory experiences. So hope that answers that. Is there anything I left out, Kate?
Yeah, I think it's, like you said, just guiding, providing that kind of guidance for staff and with families, really, just in terms of how we can protect that developing system as it comes on board, and that mainly comes through the way in which we perhaps handle or move or transfer babies out, etc. Just small pauses and pacing can be enough to also make a bit of a difference to their experiences, or nappy changes, keeping feet below head, etc. So it comes into those kind of those daily cares and interactions that we support families with.
And skin to skin, you're giving the baby that nice vestibular input while they're getting the lovely deep touch pressure from parents as well.
Brilliant, thank you so much. Genuinely fascinating, and I wish we had longer now to kind of go through all of these things, but we said we keep to an hour, so I'm going to wrap it up there. Just a huge thank you to Kate and to Amanda for giving your time and sharing your expertise. I think, yeah, hugely helpful, so really appreciate it. And a special thank you to Sharon for sparing your time to come and just explain a bit more about your experience. And I think it makes such a huge difference hearing it directly from somebody who has been through it. So huge thank you to you too, and to everyone for coming. I hope everybody has enjoyed the session. We really want to kind of make sure that we're doing more of these, so please do respond to our feedback form that we'll send around shortly. Once you've done that, you can pop your email address in for a certificate to be sent to you. So please do that. That would be brilliant. We have a couple of other events coming up. The last in this series is going to be on the 26th of September with pharmacy specialisms. So really, again, another fascinating session planned for that. And we also have another webinar that's going to be run by our campaign policy and research team on the 19th of September, which is focused on accommodation and the role that kind of being able to support families to be with their baby as much as possible, and the challenges around accommodation with that. So that's going to be on the 19th of September. All of the information and sign-ups is available on our website, and I'll pop a link in the email that I'll send around with the recording and the feedback form too. So I think that's everything from us. Thank you, everybody, and hope to see you at another event soon. Enjoy the rest of your day.
Thank you.
Take care.
Take care.